2011 session of the Psoriasis and Psoriatic Arthritis Symposium. And I want to welcome patients who are here, relatives who are here. We have our psoriatic arthritis and psoriasis team. We've seen them registering you, all standing around the room doing their jobs, official or unofficial. And there should be some industry supporters here, but I don't actually see, oh, out there. And I'll be acknowledging their contribution right here. As you can see, Abbott Laboratory and Janssen Pharmaceuticals have provided some support for this event, as well as our International Psoriasis and Arthritis Research Team, IPART, which is directed from our center here in Toronto. And through IPART, we receive funding from the Canadian Institutes of Health Research, specifically for an item called knowledge transfer, which is what we're doing today. We're transferring knowledge that we've learned from a variety of studies that we and our colleagues have done to the community to understand the progress in psoriasis and psoriatic arthritis. And this is our team from last year. We don't actually have the picture yet from this year, but just to introduce you, I'm Daphne Glad, and this is Vinod Chandran, and together we run the psoriatic arthritis component, and together with Cheryl Rosen, we run the psoriasis component of the psoriasis and psoriatic arthritis program. This is Proton Rahman, who some of you may recognize as he did work with us here in the late 90s, and he's now running his own program in St. John's, Newfoundland. And Brian Tom, who is actually here today, but not this evening, is a biostatistician from Cambridge, England, and he works with Professor Vernon Farewell and Aidan, his last name escapes me.
Okay.
And they're all from Cambridge, England. I guess Richard didn't make it last year. Don't see Richard. Anyways, and you can see Anne McKinnon, who's the administrator of our center. Fonda Pellet, who's here, who runs our research lab, together with Remy Pollack. You've seen Adele and Suda, who've registered everybody here today, and Maria, who runs the IPART program, and Renice, who runs our database, which is not just our local database, but the international database. And Lee Eder was a fellow with us last year. She's gone back to Israel at the end of August, and some of the material that we'll share with you today comes from work that she's done. And Hussein al-Asiri has gone back to Saudi Arabia, and some of the work that he's done is going to be presented at our upcoming meeting of the American College of Rheumatology. And I think, there's Jeffrey, who was a student with us last summer, and Daniel, of course, without whom the clinics would never run. And Arani is our biostatistician, sometimes photographer. I'm told I'm very quiet, so now you can hear me there. Okay, so the other thing I wanted to share with you is the information on the support that we get for our research program, which is funded primarily by the Krembil Foundation, but also by the Canadian Institutes of Health Research, the Canadian Arthritis Network, who has supported many of our summer students, and some of our research trainees, the Arthritis and Autoimmunity Research Center, the General Toronto Western Research Foundation, and the Arthritis Society. And the Bally-Tobin Foundation has actually supported our summer studentship for quite a number of years, although not in the last couple of years. So before we get into the actual presentations, I want to remind you an evaluation form, a feedback form, and we would really appreciate if you remembered to complete the form and leave it at the desk before you leave so that we can plan further information sessions like this in the future. So the plan for this evening is to have a talk about psoriasis and its impact from Dr. Cheryl Rosen. Dr. Vinod Chandran is going to talk about the risk for development of psoriatic arthritis among patients with psoriasis. We'll have a break, which may be as long as 15 minutes, but just so that we can stretch our legs in between. And then we'll have the last part, which will concentrate on outcomes and therapeutic advances. And we've left quite a bit of time for questions and answers. And the speakers will be at the front, and you can address any or all of us with questions during that period of time. So I think we'll get started, even though we are 5 minutes faster than we thought we would be. And so we'll bring up Dr. Rosen's talk and move right along. It's okay, that's the way.
Hi everyone, welcome. Thank you very much for coming this evening. I'm going to be talking about psoriasis and its impact. Yes. So as you all know, psoriasis is a disease that involves the skin and the nails. It affects 3% of the population. It's not contagious, and there is a familial tendency. And here are some examples of lesions of psoriasis. You can see the scaly plaques with the red color and how it's raised off the surrounding skin. Here are the typical nail changes with what we call pits on the surface and some onycholysis, we call that, where there's lifting of the edge of the nail from the nail bed. Some plaques of psoriasis over the back of a hand. Oh. Symmetrical plaques on the elbows, and that's very common for the lesions to be symmetrical. If you have it on one elbow, you get it on the other elbow. And another very common place is the scalp, and you can see it here poking out from underneath the hair onto the skin. Hairless skin. And here's somebody who has more extensive involvement of psoriasis, smaller plaques scattered over a larger area. So psoriasis can be itchy, doesn't have to be. It can be uncomfortable. It can interfere with a person's ability to work. If they have involvement on their feet, it can interfere with their ability to walk. It may cause embarrassment due to appearance and may change the clothing that somebody would wear so that the affected areas are covered. And in some cases, it does lead to a lowering of self-esteem. We know that psoriasis is not just a skin disease. About 30% of patients develop arthritis, and there is an increased risk of heart disease. And there's more recent evidence, and I believe that we'll be talking more about this later, that there's an increased risk of metabolic syndrome, that is diabetes, obesity, high blood pressure, elevated cholesterol, and triglycerides. So psoriatic arthritis is an inflammatory arthritis with pain and decreased mobility. And all of these factors, the arthritis, the psoriasis, the comorbidities of the high blood pressure, the elevated lipids, cholesterol, can all affect the quality of life and can have a big impact on quality of life with physical, social, and psychological effects and a stress and disruption of daily routines. And so how do you best measure quality of life? Well, a lot of people have spent a lot of time developing multiple questionnaires. They assess the effects of certain diseases, psoriasis being only one of them, on the activities of daily living, on disability, on mood, whether there's anxiety or depression caused by the problem, whether there's pain, whether there's fatigue. And several studies have reported a decrease in the quality of life in psoriasis. One study did not find a decrease in the quality of life, and we can talk about that later. Our study, which we did here, did find a decrease in quality of life in patients with psoriasis and a further decrease in patients who also had psoriatic arthritis. And the question is, how do we improve the quality of life? And a very important part of that can be treatment of psoriasis, if it's effective, if it's not too difficult to use, and if the patient, if the person doing the treatment is satisfied with the treatment. And another way to improve quality of life is also to treat the comorbidities, to treat the diabetes, the high blood pressure, the elevated lipids, and the psoriatic arthritis. And so for treatment outcomes, we look at activity scores. Many of you may know about the PSA, which is the Psoriasis Area and Severity Index, which tries to put a number to the extent of psoriasis that someone has. And we also look at improvements in quality of life. And you have to consider the adverse effects of treatment and the duration of remission. If a treatment takes months and months to work, and then before you know it, the psoriasis is back again, there may be a problem there. So I'm going to go through now some different therapies that we have available to us to treat psoriasis. In the old days, I used to say that if you didn't want to bother treating your psoriasis, that was okay. You don't want it, it's not itchy, doesn't bug you, you don't have to treat it. But now we know more and more that the inflammation in the skin caused by the psoriasis can lead to inflammation elsewhere in the body, and we think that that's why people have this metabolic syndrome, this increased trouble with their cardiovascular system, with their hearts, with diabetes, so that the inflammation in the skin can have internal effects. And so now I'm much more enthusiastic about effectively treating psoriasis. And so the type of treatment that you use will depend on the location of the psoriasis, the extent and the severity of the psoriasis, and of course the cost of the treatment has to be considered also. So we do use a lot of topical steroids. We use steroid creams and ointments and lotions and gels in dermatology. And the decisions that have to be made deal with the strength of the product depending on the part of the body that we're treating. We'll use far stronger steroid creams on the hands and the feet than we will on the skin of the face because of the thickness of the skin of the palms and the soles. And we use lotions on the scalp so that your hair isn't a complete mess from the treatment. So topical steroids have their advantages and they also have disadvantages. They're easy to use. There's a wide range of potencies. You get your choice of vehicle if you prefer a cream or if you prefer an ointment. And it can be used along with other treatments. The disadvantages, of course, is that they're not curative. Recurrences are common. There is the risk of thinning of the skin if the product is used for a long time, particularly if a very strong steroid is used in an area like under the arm, a fold. They can be expensive, and people get tired of putting these creams on, and so loss of compliance just means it's not doing what you want it to, and you stop using it. There are also vitamin D analogs, calcipotriol and calcitriol. They come as creams and ointments. They bind to a vitamin D receptor in the skin, and they act we think they act by normalizing how the skin cells grow and differentiate in psoriasis. So they're thought to slow down the whole process, and they may also be anti-inflammatory. And the advantages of these two creams, calcipotriol and calcitriol, is that they don't smell. And when I say that, many of you remember tar and anthralin, particularly tar has a lovely smell. And there's no risk of atrophy. The disadvantage is that they're more expensive and they can be irritating to some people, although often not. Their trade names are here so that you might recognize them better: Dovanex and Silcus. They're effective for mild to moderate chronic plaque psoriasis, and they can be used alone and in combination with other topical therapies, phototherapy, and systemic therapies. There's also Dovobet ointment, which is a combination of the vitamin D analog and a potent topical steroid. The nice thing about this is that it's only used once a day. It only comes as an ointment, so it makes it kind of gooey, and I always have this image of somebody working really hard in a laboratory somewhere to make it into a cream so that more people will use it. Here's just another picture of psoriasis, this time involving the soles of the feet, and you can see here that there are pustules. I don't know if I can see them from here, but there are pustules and papules, dried pustules on the soles of the feet, and you can see that if this was painful or itchy, this person might have difficulty walking, getting around. We also use phototherapy to treat psoriasis, and you may know that we have a phototherapy center here at Toronto Western. For phototherapy, we use repeated controlled exposures to ultraviolet radiation to treat skin disease. This began for the treatment of psoriasis a very long time ago because people noticed that they got better in the sun. And so we can't rely on the sun in Toronto in February, even in October. And so we have fluorescent tubes in boxes that provide us an artificial form of ultraviolet radiation or part of sunlight. And this is the whole electromagnetic spectrum. We're not going to have a physics lesson here, but generally the wavelengths that we use are this ultraviolet B radiation right here in the middle, and many of you know that we've really moved away from broadband UVB, which used the whole spectrum of UVB, to narrowband UVB, which is one particular wavelength, 311 nanometers. You don't have to memorize that, no test at the end. And there you go. And these can be extremely effective in many people, and in some people they wind up with a prolonged remission. That is, they may finish a course of phototherapy and stay clear or pretty much clear for a year, for longer. In some people, it doesn't last quite so long. Again, another picture of psoriasis. So usually the treatment with ultraviolet B radiation is about between 2 to 5 times per week. Treatments start with very low doses to avoid burning the skin, and it takes at least about or around 25 treatments to clear, and the dose gradually increases during the treatment depending on whether there's redness, that's erythema of the skin. The dose is increased by different amounts every time because the skin itself gets used to the UV and starts to protect itself by various measures, by becoming thicker, by getting a little bit tanned, and so we have to increase the dose of the UV. Maintenance therapy with UV is thought to be helpful, but there's a lot of unanswered questions. How long do you do it for, and are you increasing the risk of side effects if you keep going even once a person is clear? So we tend to stop the treatment once someone is clear instead of just continuing it to maintain the clearance. And the side effects of UVB phototherapy include burning. We try awfully hard not to make people burn, that's for sure. Some people do get itchy from it, and chronically there may be Just like sunlight, it can add to the aging of the skin. And I put 2 question marks beside skin cancer because as much as we look for an increased incidence of skin cancer in people who have UVB phototherapy, we really haven't seen it. It's certainly been seen with PUVA, which is the combination of ultraviolet A and psoralen. We don't use that so much anymore. But it really hasn't been seen with UVB. The main drawback to UVB phototherapy is the travel time to the phototherapy. It's really a geographic, what I call a geographic limitation. If you live in Brampton, or even if you live 2 blocks away, it's awfully hard to come here twice a week, or 3 times a week. And so there is a rule for home ultraviolet B phototherapy. I used to have a great deal of difficulty with this, but depending on the person, if you're really careful and you monitor it very carefully, there is a rule for having your own UVB unit in your home, as long as you don't turn it into a tanning salon. And so photochemotherapy, this is PUVA, it's a long way of saying it. The drug that we use, the P in PUVA stands for psoralen, and it makes your skin more sensitive to the ultraviolet A radiation. We really don't use it as much as we used to because narrowband UVB has proven to be so much more effective than broadband for most people. So to turn to systemic therapy, again, it depends on the extent of the disease, the location of the disease, the persistence of the problem in spite of phototherapy, in spite of topical therapy, and the lack, meaning really the lack of response. And so we do have systemic agents that we use for psoriasis. Some of them also help with arthritis, some of them don't. Acitretin or soriatane helps with the skin, but really doesn't do anything for the joints, unfortunately. There's methotrexate and the biologics, which work for skin and joints, so it's they're very nice to use because we know that they'll work for psoriasis and for psoriatic arthritis in many people, and it gets us talking an awful lot. And so with the improvement of psoriasis, there can be improvement of quality of life. There can be decreased inflammation in the skin, which, as I was talking about, can lead to decreased inflammation elsewhere in the body, ultimately leading to a decrease in the other inflammatory and the other problems that can go along with psoriasis, the diabetes, the obesity, the increased blood pressure, the increased lipids. So we think that treating the psoriasis effectively can lead to an improvement of the other problems as well by decreasing the inflammation in the skin. And that's the end, but I think the questions are at the end.
Right.
Okay?
Okay, so now that you've heard about psoriasis, we'll talk a little bit about the risk of developing psoriatic arthritis in patients with psoriasis. And that's my name, and that's where I work, and these are my disclosures. So I must say that I've received some honoraria from the Abbott and Pfizer and the other drug companies that are listed there. I have research grants from CIHR and Abbott, royalties from the Oxford University Press and the University of Network, and I get salary support from CIHR and the University of Toronto. All right, so what I'm going to talk today is about psoriasis. And when I'm talking about psoriasis and psoriatic arthritis, I'm trying to define what we call the phenotype very carefully. Because in research, there are a lot of things that are called psoriasis. You have to be very specific when you talk about the disease and what we're looking for. So, just like Cheryl said, there are about 5 types of psoriasis. And a patient might have a number of them together, but you can classify the different types of psoriasis as chronic plaque psoriasis, guttate, inverse, generalized pustular, and pustulosis. And there are some more rarer kinds which I want to talk about. So there are some pictures, and pictures. This is chronic plaque psoriasis, and what you see here is large plaques on the trunk. It's sometimes on the extensor aspects of your elbow, so behind your elbow, in front of your knees, and this is a very common kind of psoriasis. That's what we call chronic because it's present for a long time, and it's a plaque. It's like a thick thing on your skin, and that's psoriasis. But sometimes you can have guttate psoriasis or guttate, I think, however you pronounce it. Small lesions all across your body. It sometimes happens after you get a sore throat from streptococcus infection, and it could be just transient. You might have just one attack and never come back, or it can be persistent, and when you have a flare of your chronic plaque psoriasis, you can have this. Then there is inverse psoriasis. Some people have psoriasis only in the areas of skin that is opposite to the chronic plaque psoriasis or the psoriasis vulgaris. Here it's only in the folds, so in the armpits or under the breast or the groin, and that's called inverse psoriasis. That's less common than the chronic plaque. And you can have pustules when it's all over the body. It's called generalized plaque psoriasis. And then if it's on the hands and feet, it's the palmar-clustered pustulosis. But from a research point of view, most of the research is done mainly on the chronic plaque psoriasis. Here you're trying to get a select group of patients who are otherwise similar. So if you mix up the different kinds of psoriasis, it may be difficult. And also, there are fewer patients with the other kinds of psoriasis. So when we talk about psoriasis from a research perspective, we're looking for genetics or genes or biomarkers. We're looking for those associated with this particular kind of psoriasis. Now, patients with psoriasis, as you all have heard, are at increased risk of developing psoriatic arthritis. So what is psoriatic arthritis? It's not just any arthritis with psoriasis, it's an inflammatory arthritis. So there is inflammation in the joints. And the joints affected can be the hands or the feet or even the back. And it's defined as an inflammatory arthritis associated with psoriasis. And there is a marker for another common type of arthritis called rheumatoid factor, RF. And to differentiate rheumatoid arthritis from this kind of arthritis, the definition said that you should be negative for this factor, although some patients who clearly have psoriatic arthritis may be positive for this factor. But in general, they are negative. And these are some pictures. You can see that the joints affected can be the hands mostly, but also in the feet. Can affect 1, 2, almost all the joints in your body, and it can lead to destructive changes in your bones. So it's not everybody, but a large proportion get destructive changes in the joints. And in addition to the hands and feet, can also affect the spine. So it can lead to pain and stiffness of your back and sometimes your neck. And over time, there is new bone formation that kind of bridges the spine and can lead to a stiff spine. And the stiffness can be either due to pain and inflammation or due to bony bridging between the vertebrae. So these are the two kinds of, or when you say psoriatic arthritis, we're talking about inflammation in the hands and feet, and some people have also the same thing in the back. The other features that we always ask you when you come to the clinic is, do you have sausage digit? What we mean by that is what in scientific terms we call it dactylitis, swelling of the entire digit. And it's a marker of psoriatic arthritis. It's a marker of severe psoriatic arthritis. So people who have these swollen joints, swollen fingers or toes, tend to have more damage in that particular finger or toe. The other thing is we also ask about heel pain, so that whether there is inflammation in your heel, and that's a common site for what we call enthesitis, inflammation where the tendons or ligaments insert to bone, and you have basically a pain around here, and if you do an X-ray, you can either see a spur or sometimes loss of bone there, or what we call an erosion. So this can happen in the heel, which is a common site, but there are other sites on the body where this can affect you. And so sometimes you can have chest pain, you can have pain on the sides of the hip, or pain around the knees, and when you look at the joint, there's no swelling of the joint, but it's inflammation around the joint. And some people believe that this is one of the early events that happen in patients with psoriatic arthritis. And there are studies to show that patients with psoriasis, when you do ultrasound, for research purposes, you can see this kind of inflammation in these entheses. In patients who otherwise don't have any joint complaints. So this is an important manifestation of this disease. So that's psoriasis and psoriatic arthritis. And what is its relationship? That's what we're trying to understand. And so if you look at series all over the world, about 70% of patients develop psoriasis first, and then the psoriatic arthritis. So the large majority, that's what happens. In about 15%, you get an inflammatory arthritis, and you're not sure of the diagnosis, and then later when they develop psoriasis, the doctor says, oh, that is psoriatic arthritis. So the arthritis can come before the psoriasis, but it's only in about 15, maybe 20%. And in about 15%, it happens at the same time. So you go for your skin disease, and then you have some joint pain or pain somewhere, and then arthritis is detected, or vice versa. We don't know what came first, but it was there at the same time when somebody looked for it. So when we're looking for factors or risk of developing arthritis in patients with psoriasis, we are basically looking for development of arthritis in patients who already have psoriasis. So we kind of exclude those patients who develop the arthritis first, because we don't get to see them in a dermatology setting because they don't have any skin disease. But by just looking at this group, we capture almost 80 to 90% of patients. And that's helpful for us because if we go by this construct, we can say that psoriasis is a pre-arthritic condition. And so for rheumatologists looking for early disease, identifying markers for joint disease, we focus a lot on patients with psoriasis. And that's why we collaborate with the dermatologists. They said, oh, you got all the psoriasis patients, let us follow them up and find out if they have psoriatic arthritis. And that helps us understand the disease from the onset. Because otherwise, if you already have joint pain and swelling when you come to a clinic, we have missed the early aspect of the disease. And so we have studied psoriatic arthritis in our clinic for 30 years now. But over the last few years, after getting patients with just psoriasis, we've been able to get patients who develop new onset joint disease after getting psoriasis. So that's what we are trying to focus on now to understand early events in psoriatic arthritis. So close follow-up of patients with psoriasis will lead to early diagnosis of psoriatic arthritis. And that's the premise that we're working on and closely collaborating with the dermatologists. So what is the risk of developing psoriatic arthritis? Now we can look at this question by doing what we call cross-sectional studies. You survey the general population and see how many have psoriasis and how many have psoriatic arthritis, and you come up with a number saying, 10%, 20, whatever people have psoriatic arthritis. And that gives you an idea of the amount of risk of developing the disease. Or you can go to psoriasis clinics and survey the patients there and say, how many people have psoriatic arthritis? And that gives us another estimate. It is different from that you get from a general population survey. Or you can do family studies. You look at family members of patients with psoriatic arthritis and say, how many of you have psoriasis and how many have psoriatic arthritis? And that also gives us an idea. Or we can do prospective studies, meaning that you get a bunch of patients with psoriasis and follow them up every year or so and look for arthritis and then see how many of them get psoriatic arthritis. So looking at patients in the general population, there have not been many surveys conducted to see in the general population, so not in the clinics, but by evaluating people in the community, how many have psoriasis and psoriatic arthritis. This was a study done in West Yorkshire by our colleague Philip Herivel, which came up with a number of 13.8%. So what he used was a screening questionnaire and then looked at a subset of patients who completed the questionnaire and evaluated them and then came up with an estimate of 13.8%. In the US, another colleague, Joel Gelfand, with the help of the National Psoriasis Foundation, did a telephonic interview across the states and came up with 11%. So that's a number that we have, as best as we can, from the general population. And they're not, a doctor, somebody has not gone to their house or got them to a clinic to evaluate them. They just ask them on the phone, do you have psoriasis? Did somebody tell you you have psoriatic arthritis? So there is an error in that. So they're not evaluated in detail. But if you look at psoriasis clinics, the number is very, it depends on which study you do. It's the old literature said 6 to 42%, which was, not very helpful. More recent studies have said it's about 30%. And there was something in the news today about some study conducted by the National Psoriasis Foundation, which said 1 in 4, 25%. So more recent studies have come up with this number between 25 to 30%. Europe, there was a multi-center study which said 20.5%. In Scandinavia, which there's a high prevalence of psoriatic arthritis there, it's about 30%. We've done a study maybe around 8 years ago, which came up with about 30%. So we think about 30% of patients seen in psoriasis clinics, so they may have slightly more severe psoriasis than what is in the general population. 30% of them have psoriatic arthritis, and these are after careful evaluation. So that's why we have a higher number, or maybe because the patients have more severe psoriasis, because they come to a dermatology clinic, we presume that they have more severe psoriasis than somebody in the community who's not seeing a dermatologist, and maybe that is the reason why they have more psoriatic arthritis. So that question has not been answered, but we'll get to know. The other way of looking at it is doing a family study. So we did a family study all across southern Ontario about 5 years ago, 2006 I think, and we looked at 100 patients with psoriatic arthritis and evaluated as many first-degree relatives, that is parents, children, and siblings, to see how many of these relatives had psoriasis and how many had psoriatic arthritis. So that gives us an idea. So some of you might remember me coming to their house and drawing blood from some of the relatives. But anyway, the prevalence in first-degree relatives of psoriatic arthritis was 7.6%. If you just look at siblings, it was 7.7%, and if you look at psoriasis, it was 15.2 and 17.7. And if you compare that to the general population and take a look at how much increased risk a particular person is, who's got a first-degree relative, father or sibling or child with psoriasis or with psoriatic arthritis, how much risk that person has compared to a man on the street, it's about 30 times. So if you have first-degree relatives with, if one of your first-degree relatives have psoriatic arthritis, then your risk, the relative risk, is 30 times. It does not mean, when you look at an absolute risk, it's much lower, but it's 30 times the risk from somebody on the street. So it's substantial, and that's why we think there's a strong genetic influence or common family environment factor that is increasing your risk, and that's the premise by which we're looking for genetic factors for this disease. A similar study was done in Iceland, where they looked at the registry, because everybody in Iceland is on the registry, and you can look at their clinical diagnosis by linking their data to the national registry. And so they could link, in Reykjavik, they could go back to looking at their first degree, second degree, third degree, fourth degree, fifth degree relatives, and see how many of them had psoriatic arthritis. And they came up, for first degree relatives, they came up with almost similar numbers like we got, about 39. And then you go to second degree, it comes down to 12, third degree 3.6, fourth degree 2.3, and only the fifth degree relatives had the same risk as the general population. So this again indicates a strong genetic effect with at least 10 genes that would be associated with the disease. So this is the risk that we get from family studies. And probably doing a prospective study is a better way of identifying, prospectively. Prospective means you see patients with psoriasis who don't have arthritis, and then see them once a year, or maybe, or when they have a problem, and then try to identify how many get psoriatic arthritis. And that's what we've been doing since 2006. It's been 5 years now, but it's still early days. Of 500 patients that we have in this particular study, but 25 have now developed psoriatic arthritis. So that gives you an idea. And we did an analysis last year, and what we found in that particular analysis was that the annual incidence per 100 psoriasis patients was about 1.87, or about 2. So about 2 patients. So if you follow 100 psoriasis patients for a year, about 2 of them get psoriatic arthritis. It's high compared to the previous literature. We're continuing the study, and the estimates might be, adjusted later on, but it's also possible that there is indeed this high risk, and the previous studies were underestimating it. And so this study is continuing, and that's why we come to the psoriasis clinics and ask you to participate, and then give you a bunch of questionnaires and say, well, you need your blood, and then we like to see you once every year. And we're open to looking at better ways of follow-up. Ideally, we'd like to see everybody, but then as the numbers go up, if every 500 patient has to come back for follow-up every year, you're going to get issues there. So with new technology, maybe we can get a lot of work done by using a screening questionnaire, by Facebook or something. So but we are really interested in finding out following patients on a longitudinal basis, and not only looking at psoriatic arthritis, but also other comorbidities, heart disease, diabetes, because that's all closely related to psoriasis and psoriatic arthritis. So now that we know that there's an increased risk, can we identify patients with psoriasis who are going to get the disease or are at higher risk of getting the disease? Because not everybody gets the disease. And so that's the, I would say, ultimate aim of this project, so that we can identify, we can say, okay, you got psoriasis, and look at some profile and say, this is your risk of getting psoriatic arthritis. So if it's a high risk, then we like to see you very closely. If it's a low risk, we'll say, well, if you have any symptoms, you can come back to us. You don't have to worry about your arthritis otherwise. And so from doing clinical studies, we know that if you have nail lesions, the lifting and pitting that Dr. Rosen showed is an important predictor. And so if you have that, maybe it's a higher risk of getting the disease. Some people believe that scalp psoriasis and psoriasis in between the gluteal cleft is an important risk factor, and also maybe the severity of psoriasis is an important factor. We don't really know that, and I guess as we do our studies, not only here but other parts of the world, we'll get a better idea. More and more genetic studies are being done, and there are some genetic factors that differentiate between the two diseases. And so we know that HLA-B8 and B27, B38, and IL-12B is the gene involved in the immune response. The risk alleles of these genes increase the risk of having psoriatic arthritis in patients with psoriasis, whereas if you have HLA-C6 or IL-23R, you are less likely to get it. We're also looking at blood markers, and we've shown that in a small study that CRP, OPG, MMP3, and the ratio of CP2 to C are important markers that can differentiate, and we're trying to then validate that. When I'm saying blood markers, I mean drawing your blood, and it's a simple test that you can do for these markers, and putting it all into a model, we could say whether if these markers are more than a particular level, you either have arthritis or you're likely to get it. So we're working on this, and these markers need to be validated, but we hope that ultimately with a few clinical features, for example, nail disease, and maybe one or two genes and some blood markers, you could come up with a profile or a chip that says, okay, this is your risk of getting the disease or not. And it's a long process. We need to do it in multiple studies at different sites to confirm it, but that's where we are working towards, not only here, but all with collaborators in other parts of the world. And so to summarize, we can confidently say that patients with psoriasis are at increased risk of developing psoriatic arthritis, and family history increases the risk. We believe that clinical, genetic, and blood markers may help in predicting psoriatic arthritis, but as always, we need more research, and hopefully we'll have better answers as the years go by. Thank you.
Okay, so we're going to proceed, and the next part is talking about outcomes in psoriasis and psoriatic arthritis. And when we look at the outcomes in psoriasis, many patients actually have mild disease. So they have a disease that affects a small percentage of the body surface area, not requiring systemic medications, not leading to any marked functional disability or limitation, and not leading to any significant reduction in quality of life. But 30% of the patients with psoriasis develop psoriatic arthritis, as we heard, and I'm not going to belabor that because we've heard this before, and you've seen these pictures before as well. So we're just going to go on. The one thing that I want to emphasize is what actually can happen. So as we can see here, this is an individual who has, you can see the psoriasis and the nail lesions. And what you can see when we take an x-ray is that they have lost the tips of the fingers. So this individual actually thought that this was due to the fact that he came down from Timmins, where he was a roofer working in the winter. So he figured he got frostbite. And he was very surprised when we told him that frostbite does do this, but this actually is psoriatic arthritis. And the other interesting thing is that if we didn't do the x-rays, we wouldn't know that he actually had involvement of the wrist, because he didn't complain about the wrist being painful. And this is really the utmost damage that can occur to a person with psoriatic arthritis. And what this picture shows is a phenomenon called telescoping. So there is the thumb, and it measures about 2.5 centimeters. But if you pull it up, it actually goes up to a normal size of a thumb. And what's happened is, just like we see here, there is a resorption. The bone has totally disappeared, leaving a very tiny little stump-looking thing for a thumb. And of course, we have back disease. And again, Dr. Chandran made the point that this individual's back is pretty stiff. He's actually trying to touch his toes, and he can't. And the reason he can't is because there is bony overgrowth here. These are the vertebra, and in between are the discs, and these bony overgrowths shouldn't be there at all. And the same thing happens in the neck. Now you can see here that it's a very thin overgrowth over where the disc should be, and here again. So these are the kinds of problems that occur as a result of psoriatic arthritis, both in the hands and feet, what we call the peripheral joints, or in the back, which we call the axial, because it's right in the middle, skeleton. So we've learned, since we started the clinic in 1978, we learned actually pretty quickly, shortly after we started the clinic, we noticed that 20% of the patients with psoriatic arthritis actually develop clinical deformities and damage, and that results in functional disability. And when we followed people for at least 10 years, so if we started in 1978 and we followed them through to the late 80s, we found that after 10 years of follow-up, 55% of the patients had at least 5 joints that were deformed. And that was a very important observation, because in those days, people thought that psoriatic arthritis was a mild disease. You give a little aspirin, and it goes away. Well, it was not the case. Moreover, we also found that when patients came to the clinic, on their first visit, when we sent them to get x-rays, 67% had one erosion, a little bit of a nick from a bone. This was in our study. The first line is from our study. And in the Spanish study, almost the same number, 57% of the patients had at least one erosion when they came in. And from Bath, England, they showed that there was progression of erosive disease over 5 years of follow-up. But the most telling study was this study here that came out from Dublin. And what David Kane showed in that study is that 27% of the patients who came to their early arthritis clinic, so this is a clinic where people came within a very short time of onset of pain, not the diagnosis of psoriatic arthritis, just onset of pain. So they had 129 patients that came to their clinic, of over 1,000 patients with early arthritis. 129 were actually diagnosed with psoriatic arthritis. 27% of those patients already had an erosion. On the average, they were within 5 months of onset of symptoms. So that tells us that in some people, psoriatic arthritis can be pretty destructive. Now, they followed people for 2 years and showed that at the 2-year mark, 47% of the patients already had erosions, and this is despite the fact that more than half of the patients were already treated during those 2 years with disease-modifying drugs, or at least what we thought were disease-modifying drugs. And then we were looking to see what are the predictors for progression of damage. And it turns out that if you have a lot of joints involved at the presentation to clinic, that's a predictor for progression. If people have dactylitis, those digits that have the sausage picture on it associated with them, those digits are more likely to have erosions, which is the destructive part. And then we also know that the number of tender and swollen joints, in other words, the number of joints that are actively inflamed at each visit, predict what's going to happen in the next visit, and that the sedimentation rate is a measuring of inflammation, is one of those markers in the blood that tells us that there's inflammation. So if the sedimentation rate is elevated on the first visit, it is predictive of future damage. Now, one of the things that we do in our clinic is we educate. And part of the education is the doctors come and train with us, and you see a few of them in the audience here today. But the other part is that PhD students do work and develop methodologies using the information that we collect in our clinic. And this David Toulouse was a PhD student from the University of Waterloo. He works with Professor Richard Cook, who's one of our members of our team. He showed that in fact there is progression over time, and that over time it's pretty linear, so that we need to prevent this from occurring right at the beginning. Now, some of you have seen this before. We showed in the mid-90s that psoriatic arthritis is not just some form of arthritis that you learn to live with. Some people actually die earlier than they should because of having psoriatic arthritis. And again, the causes of death are the same as the general population, but the risk of death is related to previously active and severe disease. So that tells us there may be something we can do to alter the course of the disease. And this was in the mid-90s. Now, in 2007, we decided to take another look because we had the impression that we were actually treating patients better in the 80s than we did in the 70s. And the truth of the matter is, this is what we described in the 90s. And what you can see here is whether you look overall or in men or women separately, the mortality has gone down. In other words, the survival has improved. And at this stage of the game, there's only a slight increase compared to the general population, suggesting, we'll take the credit, of course, that we've done something right. And in fact, some of the other studies that we've done have shown us that we're using medications earlier. So you heard Dr. Rosen said earlier that in the past, if somebody didn't want to use the treatment for the psoriasis, she would say, okay, don't do it. Well, I was the same way. If I wanted to put somebody on methotrexate, and they said to me in the 70s and 80s, chemotherapy, that's not for me, I'm not so bad, I'd say, okay. But in the 90s, when I saw the results of our own studies, I said, no, no, no. You may not be bad enough now, but we don't want you to get bad. We want you to turn off the inflammation. And so in the 90s, we became much more aggressive in relating this information to patients and in insisting that people take medication to turn off the inflammation. And it turns out that we were treating patients earlier, we were giving them a better dose of methotrexate, and that actually translated to better outcomes. And the other thing we've learned from our studies, it's not just bad stuff, we have some very good stuff to show, that we do have patients that go into remission. Remission meaning that there are no actively inflamed joints on 3 consecutive visits, and since people come to our clinic at 6-month intervals, that means that at least for a year, a person did not have any joint inflammation whatsoever. And we found that 18% of the patients actually achieved a state of remission, which lasted on the average about 2.6 years. So quite a nice period of time. We found that men were more likely to go into remission, And people that have a lower number of inflamed joints when they first came in were more likely to go into remission. Now, when you look at remission, and if you say to yourself, like if you look like at the cancer story where they talk about remission, they say that a person shouldn't have cancer, shouldn't be on treatment for at least 5 years. When we look at our patients and say, well, who is really in remission? In other words, you cannot make the diagnosis of psoriasis or psoriatic arthritis on them. Only 6 patients were in that position. No medications, no damage, no disease. Half of the patients actually went on to flare after that period of remission, but to have a period of 2.5 years where you have no disease is actually a nice thing to have. So 20% of the patients have a severe, rapidly progressive form of arthritis, which we have seen. We believe that at least 20% of the patients have a form of arthritis which does not damage. And then we have 60% that's somewhere in between. Now, it would be really nice if when a person came to the clinic, we could do some test or a combination of tests and say, you're not going to damage, so we probably don't need to put you on these very toxic medications. Whereas you really have the markers for damage, we should really treat you hard right from the word go, and then we can maybe relax the treatment. And so identifying those patients that have severe disease and the predictors for mild disease, and identifying those patients that are likely to go into remission is really something that we're very interested in doing. And some of our research program over the next few years is going to be concentrating on exactly that. So you can see why it is very important to have the right treatment. So the next thing I'm going to do is talk about the advances of treatment in, that we've had for psoriasis and psoriatic arthritis. So I'm going to move right on to the next slide. Oh, now comes my disclosure. I usually say that I will consult anybody who would listen, and I take money from whoever will give. So what I'm going to talk about then is first, what are the goals of treatment? And the second part will be, what are the actual treatment advances that have occurred in the last few years? So we know what we're talking about. But what I wanted to highlight here is when we talk about the treatment of psoriatic arthritis, it's a complex disease. It's not one thing. We've got the skin and the nails, as we've seen, and we've got the peripheral arthritis, we've got enthesitis, and we've got the dactylitis, and we've got the back disease. So we've got all these features of the disease. So we need to look at the joints, and in the joints we have inflammation, which is in the synovium, that's the lining of the joint, and in the enthesis, which is the insertion of tendons into bones, and there is the bone resorption that I showed you on the x-rays. And in fact, some patients not only get bone resorption, but they get bony ankylosis. There is just like we saw in the spine, you can get it in the fingers, where the fingers then don't move or don't bend. And so we need to do treatments that will address all of these components of the condition. And then in the skin, we have the inflammation, and then we have this keratinocyte hyperplasia, where we get this very thick plaque. And then we have these nail lesions. So obviously, we need to address all of those issues when we address patients with psoriatic arthritis in terms of management. And so, what do we need to do? We really want to identify patients early, because we know, as we saw in the previous set of slides, that inflammation, the activity of the joints, the severity of the disease, predict the outcome both in terms of damage and in terms of survival. So we want to identify patients early. We've actually shown in a study that we presented last year, actually, that people who come to our clinic early, within the first 2 years of diagnosis, actually fare much better than those who come later in terms of progression of damage. So what do we want to do specifically? Well, we want to ease the pain and discomfort of psoriatic arthritis. That's what you care about. We want to prevent the damage to the joints. It turns out that if you already have joint damage, you're more likely to progress the joint damage. It's like damage begets damage. We want to not have damage in the first place. We want to maintain function and mobility. We want to improve and at least not worsen the psoriasis when we treat patients' arthritis. And it turns out that some of the medications that we use for arthritis can actually make psoriasis worse. So we want to be careful about that. We certainly want to improve quality of life, and we definitely want to improve survival, but we want to improve good survival. We want patients to survive feeling better, not feeling worse. So what are the therapeutic advances? Well, one of the advances that has occurred in the last few years is our ability to actually diagnose psoriatic arthritis. And this slide here depicts the CASTAR classification criteria. And although these are not diagnostic criteria, they're very helpful for individual physicians to be able to identify psoriatic arthritis early. So if a person has inflammation in the joints, or in the enthesis where the tendons get into joints, or in the spine, then we can apply the criteria. And if they have psoriasis, which can be evidenced either because they have it now, or because they have a history in the past, or there's a family history of psoriasis, they get 1 or 2 points depending on what it is. If they have nail changes, if they're negative for rheumatoid factor, if they have that, you need to know this. This is very easy for us rheumatologists, but it's not that easy for a person who's not trained in looking after arthritis patients. And so another methodology that's been developed in order to try and identify patients with psoriatic arthritis early is the use of questionnaires. So there are a number of questionnaires that have been developed to screen for psoriatic arthritis. And I'm not going to go into all of them. I just want to highlight that one of them we developed here. But these questionnaires can actually be given to the patients in the waiting room. And I'm sure those of you who are patients have had to complete those. And so they can be put in the waiting room in the dermatologist's office or in the family doctor's office. And if a person has psoriasis and they score the questionnaire where they are above the cutoff for psoriatic arthritis, then at least the dermatologist or the family doctor know that that patient at least should be referred to a rheumatologist to make sure whether or not they have psoriatic arthritis. So we now have some tools that will help us identify patients with psoriatic arthritis early. So in terms of easing the pain and discomfort of psoriatic arthritis, we also have some tools that allow us to identify response. So these are the methods that are used. This is called the ACR, which stands for American College of Rheumatology. And it says 20, 50, 70. It means a 20% response, a 50% response, or a 70% response in a set of criteria. And this has been shown to be quite effective in distinguishing patients in clinical trials, which I'll show you in a minute. The second point is we want to prevent damage to the joints. So how do we assess that? We can actually look at the radiological picture and see if we can actually prevent progression of radiological damage. And Dr. Rosen told you earlier that there are ways for us. We have questionnaires that have been developed to assess quality of life and function. And one of them is the Health Assessment Questionnaire. Another one is called the SF-36, and again, those of you who are patients in the clinic will recognize that that is one of those are 2 in the package of 8 that you do once a year. And then Dr. Rosen has already mentioned that we do have an instrument or a tool that we can measure the improvement or worsening of psoriasis. And so Here are the results of studies with new agents. So I mentioned earlier that in the Irish study, although more than 50% of the patients were treated, 47% still had erosions, and at least 20% had developed erosions who didn't have erosions at the beginning. So obviously methotrexate didn't work all that well by itself. However, anti-TNF agents, which became available to us in the year 2000, have actually made a remarkable difference. And if you look at the bars here, so the pale color here, the first one is etanercept, the second one is infliximab, the third one is adalimumab, and the fourth one is golimumab. And so it's the names that you might be more familiar with is Enbrel, Remicade, Humira, and Symphony. And what you can see is that all of them work very well. So the first bunch of columns are the treatment group, and the second one is the placebo group. So when you do a clinical trial, half the patients get the real drug, and the other half get a placebo, which is either a sugar pill, and in that case is an infusion of nothing, or an injection of nothing. And so you can see that there is some improvement in the controls, but it's in the placebo patients, but it's very low. Only 10 to 15% actually achieve this kind of response. But more than 50%, regardless of which drug you use, actually show response. And then if you go into a more stringent improvement, 50%, you can see that the response in the placebo-treated patients is now much lower, but also the response of the patients is a little bit lower. And if you look at the 70% response, there's a negligible response if you don't get the drug, but almost 30% of the patients actually do respond, and an ACR 70 is a clearly demonstrable improvement. You, as a patient, would notice an improvement regardless of what we say. You'd say, I feel great, because this is a significant improvement. And then this is another type of measure that we can do again, clearly separating patients that are treated with the drug versus placebo. Now there are some other biologic treatments that have recently come on the market. So here again, the blue is a drug called Alefacept, or what's the, Amaviv. And Abatacept is now called Orencia. And the green one is ustekinumab, which is called Stelara. And the other one I actually gave it a Apremilast because his other name is a number. And these are new medications that again have fairly good responses, differentiate quite nicely, but as you can see, the 50 and 70% responses here are much lower. The nice thing about the Apremilast is it's actually an oral medication. And we have a study that's just being analyzed now to look at, it's called a phase 3. It's a bigger study that will show us the results. Now, this table looks at the effect of psoriasis in psoriatic arthritis studies. And you can see that, again, there is a significant response. In the psoriasis, we look at the PASI, and if the PASI went down by 75%, it's considered a response. And you can see that this is the extent of the response in the treatment group compared to the placebo group. And these are the different drugs that are used, that have been used here. And just to make sure that you understand what we're talking about, here is a patient pre-treatment, and you can see that the PASI score here was 28.8, and the physician global assessment said that this was very severe. And of course, we would all say this is pretty severe. And this is after 2 weeks after the treatment. You can see what has happened. Significant improvement, and in fact, that's recognized by a marked reduction in the PASI score, and the patient and the physician would all recognize that this is almost clear, and this is maintained through 12 weeks after the last dose. So it's like 3 months after the last dose, there's still a maintained improvement. So this is quite impressive, and it doesn't matter, this could be, I can't even remember which drug this is. but it could reflect any of the drug trials show you the same kind of response. So that's looking at the symptoms and signs, the skin and the joints. Now what about the health-related function, the health assessment questionnaire? The health assessment questionnaire is scored on a 0 to 3. 3 is terrible, and 0 is better than normal. Even normal people have 0.1, 0.2. So when we have in psoriatic arthritis a value of 1, that's considered a pretty poor function. But they've all had a significant reduction. Again, it doesn't matter which drug you use, almost a 50% reduction, and it's sustained through the years. So there's been a remarkable improvement in function. There's also been a remarkable improvement in radiological change. And when they first showed us these results that suggested the minus means that things got better, we said, wait a minute, how is it possible when you have the damage that we saw that it could get better? It's not possible. If they said, okay, it didn't get worse, I could accept that. But to tell me that it got better, no way. The answer is, it's true. And here is the example. So this is a paper that Mihi Eder, who's one of our fellows that just left, wrote with us. And you can see, again, those lysis of the joints. So this occurred in 2005. And the same thing happens in the feet. I wonder if you could maybe turn the lights down. Those are the front lights. See, that's better. Look at the destruction here and here, those 3 areas. So this person came back in 2007, and when we read the x-rays, we didn't actually recognize that there was some improvement here. But when she came back in 2009, we saw almost a normal joint here. Now compare this joint to this joint. It's unbelievable. We had to go back and check the patient's name and the medical record number and the date of birth to make sure that we actually got the right person. But that's what happened. And we actually have a number of methods now to assess x-rays, and we could show that with each of those methods, it was easily demonstrable that there was improvement in these joints. So we're now saying, you know, these drugs not only prevent progression of joint damage, but they may actually heal. Now it's possible they can only heal those joints that have this fluffy appearance that suggests that there's a lot of inflammation, but we still need to investigate that further. So one important thing when we look at drugs, new drugs or old drugs, is lights. I'm getting these messages. So one important thing to remember when we're looking at treatment is how safe is it? So those of you who come to my clinic and you ask me about a new drug, does it have any side effects? My usual answer is, even crossing the road may have a side effect. So everything has a side effect. The important thing is, are the side effects from the drug serious, more common than if you take a placebo? And when you compare the effect of the drug versus the potential for side effects, which way does the pendulum go? And it turns out that the anti-TNF agents are relatively safe. The main side effects have been either injection site reactions or infusion reactions, depending on which way the drug is administered. Infections have been an issue, and of course we are interfering with the immune system in a big way, and so infections are expected, and they do occur. Dr. Haddad, who's been here, I don't know if he's still here, but oh, there he is, right at the back. He's been with us now for 6 months, and he's already performed a study on infection in psoriatic arthritis, and has shown, he's going to be presenting it at the meeting next month, and he's shown that the infection rate in psoriatic arthritis and psoriasis is probably greater than what would be expected in the general population. And if patients take anti-TNF agents, the infection rate is even higher. So it's clear that the anti-TNF agents are associated with infection, but at the same time, they give a lot of patients an almost clear skin and almost no actively inflamed joints. We do have quite a number of patients that are in clinical remission now. And the other concern that we have is about malignancy. We're using drugs that are called anti-tumor necrosis factor. So there's always a concern that if you remove this anti-tumor necrosis factor, you may be interfering with the body's ability to reject cancer cells. We have not seen a significant increase in cancers in our psoriatic arthritis patients, not just ourselves, but in the literature, it has not been a significant issue. So if we look at what has happened, is we can now identify patients with psoriatic arthritis early. We can ease the pain and discomfort from the disease. We can prevent damage to the joints. We can maintain function and mobility. We improve the skin and the joints with these drugs. What we don't know yet is whether there's been improved survival. We think that there may be some circumstantial evidence to support that. And that comes from a recent study that was published from Bath, England, where they showed that there is no increased mortality in their psoriatic arthritis patients who have been seen over the past 10 years. And it's over the past 10 years that we've had these anti-TNF agents. So we think that there is some indication that the use of these medications is actually helpful. So in summary, there have been major advances over the past decade. New drugs have been absolutely life-changing for patients. Not all patients respond to these medications, so we still are in need of new therapies that would work at least for those people who either cannot tolerate these drugs or do not respond to drugs, so that we can treat all of our patients with the same degree of success. And with that, we're going to close the formal part of the evening. Thanks for your attention.
Someone has to start. Oh, there's someone.
In the last part of your presentation, you gave a lot of information on the anti-TNF drugs, but not so much in the biologics. Was there a reason for
So
that?
anti-TNFs are biologics. So what I've shown you is I've shown you the anti-TNF agents, and I've shown you the other biologics that are not anti-TNF that work by slightly different mechanisms, dealing with other areas of the immune response. The difficulty is that we don't have as much information on the other drugs as we do about the anti-TNF agents because they're more recent. They're still in clinical trials. So for example, Amaviv, which has been used a lot in psoriasis, has actually been approved for psoriasis, doesn't work very well for psoriasis, certainly doesn't work very well for psoriatic arthritis. So there's really nothing to tell. Ustekinumab is still in clinical trials. It has been approved for psoriasis and actually works very well for psoriasis for a large number of patients, but its effect on psoriatic arthritis, while has been suggested in one phase 2 trial, has still not been proven. There are 2 trials underway, and we probably won't have the results of those until next year. And the apremilast, as I mentioned, is still in clinical trials as well. So I've concentrated the information, the advanced information that we have from the anti-TNF agents, which are biologics, but not the other ones, which we just don't have as much information on at the moment. So, Ronnie, there's a question up top there.
Oh, there's one here.
Oh, one here? Okay, well, I can...
Hi, my name is John. I've done an awful lot of research, and I read someplace where possibly trauma brings on psoriatic arthritis at an earlier age. I'm 50 and started methotrexate almost 2 years ago. I had a body cortisone shot that lasted 3 years. My second one lasted 3 months, and I started approximately 2 years ago, February, on the injections. I'm at the max dose now. But is it true that trauma that I went through in 2004 could have brought it on?
Well, certainly studies that we did in our own center, that Dr. Eder actually published last year? This year, early this year, actually confirm that trauma is one of the risk factors for psoriatic arthritis in patients with psoriasis. Yeah, it doesn't cause it, it just increases the risk. And
My understanding, it brings it on earlier.
it may bring it on earlier.
Hi, sorry, can I just ask, you talked about the anti-TNF drugs and the success figures. I was just wondering how they compare to the likes of methotrexate. So, is it more or less successful? That's kind of my questioning.
Okay, so the true answer to your question is, we do not know, because there's not been a study comparing any of the anti-TNFs directly to methotrexate in psoriatic arthritis. In psoriasis, there was a study comparing methotrexate with Humira, and it showed that the Humira is better. Yeah. And one of the problems that we have with the methotrexate studies is that the wrong doses have been used. We now use doses that are between 20 and 25, and we give it by injection. And in most of the studies that have been published, they use doses of 15 milligrams given by mouth. So the truth of the matter, we don't know. However, half the patients that were included in the clinical trials had taken methotrexate, and it didn't work. And when you added the anti-TNF agent worked. So we're assuming that the anti-TNF agents work better than methotrexate. But we do not have a direct answer to that question.
Thank you.
Yes, thank you first of all for organizing this symposium. I have a question, of course, related to my personal interest in it. What about leflunomide? Is there any new information on use of leflunomide as one of the DMARDs used against psoriatic arthritis?
So the information that we have on leflunomide is based on one randomized controlled trial, which showed that it was effective. Unfortunately, the trial did not include X-ray as an outcome, so we do not know what the effect of leflunomide is on progression of X-ray. We also have, there's a study that was done in Europe that showed that in the regular clinic, leflunomide works. They also did not do any, they didn't look at X-rays. And we have a study that was just completed in our center that showed that after a year, about 50% of the patients actually had a response, and it turns out that the skin response was better in individuals who also were on methotrexate. About a third of the patients were not able to continue on the leflunomide, primarily because of side effects. So only about 2/3 of the patients continued.
Side effects would mean mostly diarrhea and hair loss.
Now, our personal experience is that if some patients respond, if they respond amazingly well. If they don't respond, they don't respond. So we usually, some of you may know that in order to get an anti-TNF agent in the province of Ontario, you have to have failed both methotrexate and leflunomide. And so what we often do is when we think a patient deserves to get a biologic, we quickly give them methotrexate and leflunomide. And one of the reasons that we can't object too much to the trial of these medications is because we have been surprised by patients actually doing very well on leflunomide without actually needing the anti-TNF agent at the end of the day.
Hi, my question is that, I know that you said that the disease has a genetic prevalence to it, but in a situation where you've been unable to trace that to a genetic factor, has there any studies been done in the possibility of gene mutation?
So, when you say gene mutation, that's basically looking at a genetic factor. So,
No, it's inheritance, like a sibling had it, or a parent, like a parent had it and the sibling, the
so,
child
so
got it.
genetic studies
But in the
are,
absence of that,
right. So, any disease except for, say, roadside accident, there is a genetic factor and an environmental factor. So, for example, even diseases like HIV infection is caused by a virus, but if you get AIDS or not depends on your genetic profile. The same way, diseases like, say, Down syndrome, you have a problem in a gene, you may get the disease, but how the disease how the disease presents itself depends on the environmental factors. So that's the two extremes. But all other diseases, including psoriasis and psoriatic arthritis, there's a genetic component and environmental component, on average. Some patients may have a strong family history, and if you genotype, we don't know all the genes yet, but some of the genes that have been identified, you can find it in the families. And some, you look for the known genes variants and you don't find it. And we presume that that's all mostly environment. Environment means the infection, injuries, all that can trigger the disease. So, so it depends on the disease. There's a strong genetic component. A lot of people have family history of either psoriasis, psoriatic arthritis. About 40% have that, but a lot of them don't have it. So you cannot attribute everybody's disease to a genetic factor, but compared to other diseases, this particular disease has a lot of genetic factors, and there are probably variants of the gene which help in, for example, the commonest risk factor for the arthritis, the biggest, strongest risk factor that we currently know is B27, which is also associated with ankylosing spondylitis. And this particular gene is good to have it, especially in places like Africa where there's high prevalence of HIV disease. Patients who have B27 they're kind of resistant to the HIV disease. So probably these genes came up, was selectively transmitted through the generations because it helped in getting over the infections many thousands of years ago, but now, as there are not many infections left, it kind of acts, the immune system is hyperactive and affects your skin and joints. And so that's the theory behind it, but I don't know if I answered your question, but that's the thing.
Hi. Just a question with regards to triggers for psoriatic arthritis. I recall when I was about 12 years old, my father developed some kind of a severe infection and required antibiotics. And then he developed psoriasis around age 30-something. And then I developed it after severe illness as well. And again, antibiotics were involved. Could they be a trigger in terms of affecting microbial organisms and wiping them out? And then, is that a possibility? I'm just curious.
So again, in the environmental study, infections requiring antibiotics came up as an environmental factor associated with the development of psoriatic arthritis. But exactly why that happens, we haven't quite figured out yet. It's possible that the antibiotics unraveled something that was there, but we still don't know. This is something that needs to be done prospectively as opposed to data that's just collected on the computer.
Hi, I'd also like to say thanks for this informative evening. My question is, we've always been led to believe that psoriasis is a skin disorder, and recently I've heard some discussion, and I just need to be enlightened or clarified, that it's really a connective tissue disorder, or some people are talking about it being a connective tissue disorder. Can you elaborate on that a little?
I think that's pushing it a little bit.
Okay.
psoriasis is, the psoriasis itself affects primarily the skin, but as you heard from Dr. Rosen, it's not just skin deep. We now know that there is systemic manifestations. Arthritis is one of those things, but we have the other comorbidities, the metabolic syndrome, which includes obesity, diabetes, hyperlipidemia, heart disease, and hypertension. So we know that it's more than just skin, and in fact, it's now referred to as psoriatic disease. But it's not really a connective tissue disease in the sense that lupus is a connective tissue disease, or that Marfan syndrome is a connective tissue disorder. Those are the first one is a classic autoimmune disease that affects the connective tissues, and the second is a genetic metabolic abnormality that affects the connective tissues. In fact, we usually correct people when they call psoriasis and psoriatic arthritis an autoimmune disease. We don't think it's an autoimmune disease because it doesn't have the same antibody production that rheumatoid arthritis patients have with the rheumatoid factor, or lupus patients have with the anti-nuclear antibody. But psoriasis and psoriatic arthritis are in fact immune mediated. We know that the reason that the anti-TNF agents work is because there's too much TNF in the blood and in the skin and in the joints of people with psoriasis and psoriatic arthritis. And we know that, for example, the IL-12/23, to which ustekinumab is directed, the gene, there is a specific polymorphism associated with IL-23 receptor, which is unique to psoriasis and psoriatic arthritis. So there is an immune abnormality. It's immune mediated, but it is not a connective tissue, and it is not an autoimmune disease as some of the other diseases are. Daniel, somebody go.
Hello, my name is Ralph. I want to know if psoriasis is a progression from dandruff, which is a fungus, and is it common for psoriasis to go on your eyelid, which is where I'm having a problem? And also, is there any similarities or common between leprosy, psoriasis, and dandruff?
Well, dandruff is a form of scaling of the scalp. And so you can have scaly scalp with several different skin diseases, one of which is psoriasis, one of which is seborrheic dermatitis. And there are treatments for seborrheic dermatitis that are actually antifungal, like an antifungal shampoo or wash. But we don't really know why it works because seborrheic dermatitis isn't really caused by a fungus as far as we know. Somehow these treatments must be anti-inflammatory, but it's not really a fungus. Now, that's not to say someone can't have a fungal infection of the scalp, but that's a completely different appearance than dandruff. So there's also an overlap between seborrheic dermatitis, which is just scaly scalp, and sometimes people get scaling in their eyebrows and the sides of their nose from that too, and that you can have a lot of dandruff. That can overlap with psoriasis, and then, of course, we have a name for it. We call it sebopsoriasis. So you can have overlaps of these different things, but dandruff isn't specific to one skin condition.
How are you going to tell the dandruff attack on the eyelid from the psoriasis? Like, how do you know whether the psoriasis or dandruff attack?
On the eyelids?
Yeah, and also these, this medicine like Enterol, does it promote psoriasis? Because I think my psoriasis are increasing.
On the Enbrel.
Yeah.
Well, it doesn't, Enbrel doesn't work in everyone, that's one thing. And mostly psoriasis is a diagnosis that we make clinically by the appearance. It can look very similar to eczema in some cases. Certainly the location helps us. Eczema is more common on the eyelids than psoriasis is, but you could get psoriasis there. For instance, there's certain places that psoriasis is more likely to go to than eczema. But it's usually the clinical appearance and other things in response to treatment and other things that are going on.
Leprosy doesn't enter.
No, no, except in the Bible and the translation from the Hebrew.
Hello. Here. It's my personal question. I just wanted to know, I've been taking Humira for the last maybe 2 years. It has definitely improved my life, 100%. I'll tell you that much. The thing is that what I'm concerned about is when you are saying that you have seen some reversal of bone destruction, and I'm wondering that I'm taking Humira every 2 weeks. For the past 6 months, I've been feeling so good, so I've been taking it, delaying it 3 weeks, then 1 month. So I just want to know that is that a good thing to do, or should I still continue every 2 weeks?
It's a very good question. Again, we don't have any specific evidence-based response to this, but it's exactly what we've been doing. When patients are doing extremely well, we feel that the medications are very expensive, and in any event, if a patient's going to be as well off medication as they are on medication, you'd really like to get them off. And so we do try to space out the medication, and in some cases, we've been able to get patients off the drug for at least for periods of time. So I think you're doing the right thing.
Okay, great, thanks.
And one more question about more traditional medication. In combinations of methotrexate and leflunomide, has there been any research done on pulsating the therapy using the same approach that when there is an improvement you can lower the dose or stop therapy altogether? Because I'm looking at side effects, I'm looking at the liver damage that has a high potential there. Is there anything, because at my age I'm looking at another 40, hopefully 50 years of using those drugs, and I just wonder what my liver will look like at the end of the process.
So the first thing we can tell you is that the combination of leflunomide and methotrexate did not cause any more side effects than leflunomide alone or methotrexate alone. So that's reassuring. Now, the difficulty that we have is that when you stop methotrexate, you sometimes get what we call a rebound, which means both the skin and the joints become very inflamed. And so we've actually been inclined not to stop methotrexate unless there's another drug to take its place. So if we've started somebody on Enbrel or Humira or infliximab or Symphony or even ustekinumab, we would try and reduce the methotrexate. And with Enbrel, we've actually been able to discontinue the methotrexate. We're less likely to discontinue it when we're using the anti-TNF antibodies because we worry about production of antibodies to the antibody. I recently heard one of our colleagues from the States, a dermatologist, who actually is not keen at all on discontinuing the methotrexate, even in the context of response to anti-TNF agents, because he's worried about us allowing the inflammation to come back. So we've tended not to do that. Most people decrease the dose, but Bruce doesn't think we should be doing it. So, yeah. This gentleman had a question here.
Thank you. Very impressive seminar. If you've had psoriasis for many years, and it doesn't seem to get any worse, as time goes on, are you less likely to have it turn into arthritis?
It's a very good question. In fact, we used to teach that psoriatic arthritis usually occurs within the first 10 years of psoriasis. But our own research proved us wrong. It turns out that the risk for developing psoriatic arthritis is constant, like a straight line. So that we can't be assured that if you didn't get it so far, you're never going to get it. One of the things we know is some of the genetic and other biomarkers that we've done would suggest if you don't have nail lesions, you're less likely to have it. If you have HLA-C6, you're less likely to have it, or if you're going to have it, you're going to have it later. But we used to think that we can relax, but the answer is no, can't.
One other quick question. Are there any dietary changes that could lessen, okay.
That's a very good question. But again, we don't, there's no evidence to support any dietary influence at all. But remember that we now have the issue with the comorbidities. So if we're talking about the risk for hypertension, you certainly want to reduce your salt intake. We're talking about hyperlipidemia, which is high cholesterol, high triglycerides. You want to make sure that you don't eat a lot of fatty foods. You want to reduce your sugar intake because diabetes is an issue. So from that point of view, we know that the diet does matter. The other thing that's interesting is although there are no specific nutrients or a specific diet that works or doesn't work, it turns out that if you lose weight, especially if you're overweight, if you lose weight, your psoriasis and possibly the arthritis get better even without specific treatment intervention. So that's something to keep in mind.
Me again, I'm trying
John.
to share with everybody, yes, John. 2 footnotes. 2.5 years ago, I went to a program for 3 months of living for concurrent disorder. While I was there, within 6 weeks, I have mild inverse psoriasis. Am I pronouncing that right? Within 6 weeks, where I had no pressure, no outside contact with the world, it cleared right up. So for me, stress is huge.
Now, if you can bottle this.
Go hide someplace where you love it. But anyway, the other thing is that just before I got on to, I went through naproxen and Arthotech, and I lost the use of these 3 fingers, and they started getting deformed on me. Once I got on to methotrexate, this hand is just like it used to be. It was just absolutely incredible. The other thing that scares me is that you mentioned cancer. A year ago, they did a biopsy, and I had, hopefully I'm pronouncing this right, squamous carcinoma.
Squamous cell,
Yeah. And I went through the operation, went through chemo, went through radiation that finished in June. Saw the surgeon, and I'm not finished with it yet. Is there any connection between the two? And my second part of the question is, they asked me to stop the injections during radiation.
Where was this squamous cell?
Right on my anus, where the sun doesn't shine.
It's probably unrelated to anything that you have. It's unrelated to the psoriasis or the arthritis.
I went through quite a bit of pain going off the injections, and then obviously the chemo and whatnot. Do I go off the injections if I have to go back for more treatment?
Generally speaking, we stop the immune-modifying drugs when we get chemotherapy, because the chemotherapy in itself can modify the immune system, and so we don't like to mix those. So we generally suggest that people get off the methotrexate, certainly the anti-TNF agents, if they have any chemotherapy. So we'll take 2 more questions. All right, 3 more questions.
Hi, I'm just wondering about the relationship between pregnancy and arthritis. I've had 2 pregnancies now, and I've gone into complete remission. And I'm just wondering why that is, and is there any medication that's close to that without, having 5 kids?
It's called a birth control pill. No, seriously, it has to do. We think it has to do with the estrogen that is released during pregnancy. And the truth of the matter is, 90% of the patients with inflammatory arthritis get better during pregnancy. 10% don't. In fact, some patients develop the arthritis during pregnancy, but the majority actually do get better. And cortisone, by the way, was developed because in the 40s, they recognized the fact that rheumatoid arthritis got better during pregnancy, and when they took urine from pregnant women and tried to figure out what was being released, and that led to the discovery of cortisol. So there definitely is a factor there which is not totally being sorted out. What was the next one?
Hi, you had a question earlier asking if there was any relationship between diet and maybe the outbreak or the incidence of psoriatic arthritis and psoriasis. And you said that there was no evidence to suggest that there was. I'm wondering, does that mean that studies have been done extensively? Have there been studies done to show any relationship perhaps between vitamin or mineral deficiencies and the onset or improvement in disease?
So we actually did a study on vitamin D. It made it to the newspapers, and showed that the vitamin D deficiency that occurs in psoriasis and psoriatic arthritis is similar to the general population. Some studies have been done. They're not, the studies on nutrition traditionally have not been as carefully done as the studies on other factors and treatments. But the one study that tried to look at nutrients and specific diets in arthritis actually showed that in individual patients, what they ate might actually have caused a flare of their arthritis, but it wasn't the same thing in every patient. So that's the difficulty in doing these kind of studies.
Can I just add one thing? Thank you for this wonderful seminar. It's been great to listen to. And I'm a naturopathic doctor, and I just wanted to comment that I've witnessed over 11 years of clinical practice of people with all sorts of inflammatory things, that when they identify food intolerances and allergies, it helps as a general, it won't, I can't necessarily, no one can guarantee that you would eliminate something that would cure a disease, but certainly I've seen clinically that it significantly decreases inflammatory response in the body.
Right, but it's individual related, and that's what I just described, exactly.
Yes. So just to confirm.
So if people are lactose intolerant,
exactly.
and they stop eating dairy products, they actually feel better.
Right.
And sometimes their skin and joints get better. But it doesn't mean that everybody who's got psoriatic arthritis and psoriasis should stop eating dairy food, because it's not going to work.
Right.
And then some people have done tomatoes, eliminate tomatoes, eliminate eggplant. It doesn't work for every person. But for people, individual people who say, I noticed every time I drink alcohol, my joint pains get worse. I usually say to them, listen to your body. Don't drink alcohol. One has to listen to one's body and react appropriately, but we can't give the same advice to every person just because somebody got better with this particular treatment. Somebody's got a microphone. I think we have
One more.
Okay, this is going to be the last one.
Thank you very much for the seminar. It's been wonderful. I do have a personal question that I just thought of. I'm a fairly new user to methotrexate, and it's just been absolutely incredible for me. And I haven't thought of all the questions to ask, but what is a longer term, if I continue to take the same dose and it's as good as it is right now, what is the sort of future? Does your body get used to it, and then you get the psoriasis get worse with taking a particular dose, or does it sort of stays the same rate, or does it get better? I'm just sort of wondering the long-term effect and the incidence of psoriasis getting
So
better.
we've not actually recognized a tolerance to the drug. In fact, the dermatologists in the past used to give the methotrexate in spurts. So you'd get it, as soon as you got better, they'd stop it. In psoriatic arthritis, our initial approach has always been that you have to stay on it unless you really go into remission. And at that point, we would very, very slowly try to reduce. But generally speaking, people who respond, and they stay on it. Now, there are some patients who eventually may flare, and we call that secondary failure. In other words, initially they responded, but after a period of time, there may have been a flare of the disease, and if they flared on methotrexate, sometimes we just increase the dose a little bit, and sometimes we just have to switch or add another medication. But the expectation, just on general principles, would be that you should continue to do well. The difficulty that we've run into is people stop the drug, and then they get worse, and sometimes we can't recapture them.
Thank you for letting me be your last question.
There's a lady
the
second question.
I'm just wondering if there's a point where first degree relatives should be screened. So at what point are we looking for markers in the blood? At what age do we wait for something to happen and then bring our children in? Or as if we're already diagnosed, should we be putting our children on the screen there?
So one thing is clear, that first degree relatives are at increased risk, and that's clear across studies done in the UK, in Ontario, Iceland. So, at least in the European population, first degree relatives are at increased risk. So then the question comes about screening. So how do we screen it? Screening, the idea would be to diagnose somebody early. So if there are no symptoms, and especially if there's no psoriasis, although the person is at increased risk, it may, the chance of having psoriatic arthritis is going to be very little. Now, if you have psoriasis, because like I showed you, many people get the arthritis after the skin disease, I would say if you have psoriasis, then at least you should be evaluated for psoriatic arthritis along with your psoriasis, and then at least periodically, we don't know how frequent, but at least if there is a symptom, or maybe once every 5-10 years, it would be important. The key thing is to diagnose early, so that most of the inflammatory diseases, early diagnosis and treatment will prevent adverse outcomes. So I would say we don't have any studies to show that the approach that I'm advocating is good or bad, because that is not being done. But to me, if somebody has first degree relative with psoriasis, they should be screened at least once.
Okay, so until the psoriasis, hopefully it will never
Because,
appear, but if it does.
because at least 85-90% of the time it comes after the psoriasis. So when you look at arthritis, that's the thing. The other problem is that suppose you have genetic markers for the disease and you do it, it's positive, but you don't have the disease, but you're at risk of disease. Can you do anything about it? No. So then you're only going to increase anxiety. So there's no, I think it should wait at least for the psoriasis.
Okay, thank you.
The real last one.
First of all, I'd like to thank you very much. I've heard quite a bit tonight. I have one question. I'm on Dolobet on the cream. Now, is there anything I can do to prevent arthritis from happening, like exercise, yoga?
If you can figure it out, it's a Nobel Prize question. The truth of the matter is, at the moment, we do not know how to prevent it. You've heard that there are environmental factors, there are genetic factors, but we can't change the genes, and we can try and prevent injuries, or infections, but not going to get us too far. So the truth of the matter is, at the moment, we do not know how to prevent it. We're hoping that maybe treating the psoriasis may do something. Yeah. Okay, thank you very much for participating. Don't forget to give us the comments so that we can plan a program for next year.